Hello, good evening. First of all, welcome to my esteemed faculty who has traveled across, and to all my delegates who have joined online as well, who are here physically. So thank you very much on behalf of Integrace. I am Dr. Shobhit Seth. I am the Chief of Medical Affairs. And it is a privilege to welcome all of you who are virtually and who are present physically here in Chennai. So I'll just brief you about my company. I work for Integrace, and we have built the organization on 3 values, which are innovate, impact, and inspire. The company was launched in 2019, and from a single division, which was catering to orthopedic surgeons, we have moved to 4 divisions. Now we meet orthopedic surgeons, general surgeons, physicians, gynecologists, and we also reach out to hospitals. We have a dedicated division of HospiCare, and we have an alternate channel. It is like your Amazon, Tata 1mg, we are there also available. So how has the journey been in these 7 years? We have moved from 42,000 doctors covering all over India to around 86,000 doctors. We have impacted lives of more than 100,000 patients through our prescriptions which have been generated by you. We have been the choice, the trusted partner for more than 51,000 doctors. Just to add to our achievements, we have an application called as a WeConnect application. To give you a brief about it, some context, that it was launched during the COVID. We started it as a telemedicine app. It was a gateway for our webinars. Now we have a fully dedicated AI tool content which helps you to do multiple things. It can assist you in your day-to-day practice by providing you inputs as a second opinion. You can check the X-rays, you can check the MRIs, the PET scan, the CT scans. Of course, the efficiency is around 85 to 90%. It cannot replace the human mind. We have, like physiotherapy assist, we have manuscript also writer where doctors can create their manuscripts with the giving prompts, and it will help you faster. In 5 minutes, you are ready with your review article or an article with on any content which you like. It gives you the references, and of course, you need to check the plagiarism where it is. You need to really work out, and then you go for the publications. So there are multiple things what Integrace has been actually providing doctors. We have had initiatives like BOOT, that is Best of Orthopedic Techniques for our orthopedic doctors. For the past 7 years, we are doing that program. Then for gynecologists, we have Origin. And for the consulting physicians, we have Power Webinars. So what does Integrace stand for today? Well, Integrace stands for Leadership in Management of Peripheral Arterial Disease. Well, we have brands like Silistazole brands of Stilos. And we are also leaders in managing of neuropathic pain, vulvovaginal infections, MRSA, and of course, we have drugs for medical termination of pregnancy. I have with me today 3 eminent speakers. The first one is Dr. N.N. Khanna sir. He is a professor from Indraprastha Apollo Hospitals. He is a lead consultant cardiologist, North India, for Apollo Group of Hospitals for its endovascular services. He is a coordinator for cardiology, cath lab, and vascular services. He is the past president of ICC, that is Indian College of Cardiology. He is the chairperson and the chairman of Asia Pacific Vascular Society, president, International Society of Endovascular Specialists, Indian chapter. He is a member of governing council of multiple societies in India and abroad, and an editorial board member for journals published in endovascular therapy. Of course, both Indian as well as international journals. So I welcome Professor Dr. Khanna on behalf of Integrace, and I will request Mr. Nitin Chauhan to please felicitate him with a bouquet. I have speaker Professor Dr. Jayalal, who is currently the Dean of Tirunamalai Government Hospital, and He is a senior consultant laparoscopic surgeon from Annamalai Hospital, Kanyakumari. It was a pleasure meeting him when he was a HOD at Kanyakumari Medical College, and now he is moved to being the dean. Sir is also the president of Commonwealth Medical Association of UK. He is a national head of IMA UNESCO Bioethics at Hafia, national president 2021 for IMA headquarters New Delhi, chairman National Family Welfare Scheme, chairman ASI Kanyakumari, and of course, member of different societies, surgical societies of India, of course, of UK also, where he has done his FRCS and PhD. I have with me my co-colleague, I'll say an orthopedic surgeon by qualifications, and he is the past president of the foot and ankle for orthopedics. He currently heads the division of foot and ankle at Lakeshore Hospital. He has been trained in US and Australia for foot and ankle surgery. He is currently the vice president of the Asian Federation of Foot and Ankle Surgeons and a president-elect for the same. He has held positions of repute like the past president and the honorary secretary of Indian Foot and Ankle Society for 2022-23, and has been the past president of Cochin Orthopedic Society and past joint secretary for the Kerala Orthopedic Association. So I welcome you, Professor Dr. Rajesh Simon, sir. So I will request Mr. Nitin Chavan, who is our business head, to please felicitate Dr. Rajesh, Dr. N.N. Khanna, sir. I have Dr. Jailal, sir. Please felicitate Dr. Jailal, sir. And Dr. Rajesh Simon, sir. Thank you. So, not taking much of our time, of the audience who is there patiently waiting here as well as online, I'll request Professor Khanna to please come on the podium and start with this deliberation on the sugar-coated arteries, what he has created, so that we benefit from his knowledge, his experience of the past and present. So I request Dr. Khanna to please come on the podium.
Thank you, Integres, for inviting me for this talk. This is one subject, peripheral arterial disease, which is very, very dear to me. It's been a passion and a crusade for me since 1998. This is the time when this therapy and peripheral interventions came in the world as a in thing, and that's when I am an interventional cardiologist. I went to France and US and did my second fellowships and trained into vascular interventions apart from coronary interventions. And that's when we started. We came back and in 1999, end of 1999, we started a program at Escort Heart Institute on vascular interventions and global vascular interventions. Subsequently, we have been running clinics and programs and vascular interventions and training courses, and now we have the international fellows coming us to join and learn vascular interventions. And I must thank at this stage Integrace for helping out and especially actively partnering in Asia Pacific Vascular Interventional course year by year to spread this knowledge, to train the doctors at large and also interventional cardiologists, radiologists, and vascular surgeons to actually learn techniques of vascular interventions, vascular disease, and also, to understand vascular disease and arterial disease in a big way. Again, I would want to especially acknowledge the role of Integrace in vascular. You can take this out, I suppose, echoing. So let me acknowledge the role of Integrace in partnering and in the development of Indian consensus statement for the management of lower extremity peripheral arterial disease. Dr. Seth has been a very instrumental person in leading Integrace to develop this consensus. And this is the only guidelines available in our country for managing lower limb extremity peripheral arterial disease. You can see this is a published literature. If you go and Google it, you will find it as the #1 search. And if you see the panel of experts which actually deliberated and got to this consensus was a mix of cardiologists, cardiovascular surgeons, vascular surgeons, radiologists, endocrinologists, podiatrists, and also people from AI and lipidologists. So all together have actually gathered together and formed this consensus. Now the presentation which I am going to talk about, the sugary peripheral arteries and its association with CAD and PAD, is basically derived from this consensus statement, which was published in the Indian College of Cardiology. It's also available in the net. It's also available in the WeConnect, which you have. Now, if you look at peripheral arterial disease, how it manifests, this is one form of atherosclerotic cardiovascular disease which affects about 236 million people worldwide, and in India we account for more than 1/4 of peripheral arterial disease which is prevalent in the world. It may present with classical claudication, and then it is very easily recognized that the patient is walking a certain distance, has severe cramps or pains in the leg, and which gets relieved by if he sits and takes rest, and then he can walk more. So this is a classical presentation of claudication, but apart from that, it may also present with atypical symptoms. It may be asymptomatic, and it often, you have atypical symptoms, especially in patients who are diabetic, who have chronic kidney disease, patients who are old and have peripheral neuropathy, and therefore the need of early diagnosis and aggressive treatment and management is very important. More than that, it is a precursor or it is an indicator or surrogate marker of existent coronary artery disease and peripheral artery disease. History and physical examination remain the cornerstone of PAD diagnosis. If you look at it, it is associated with higher rates of amputation and limb loss. It is association with very high incidence and prevalence of myocardial infarction and stroke and death. Combined together, we say major adverse cardiovascular events. And it is also associated with impaired quality of life, walking performance, and functional status of an individual. Now, again, as I told you, there are different subsets of this disease. It could be a totally silent disease, or it could be presenting with typical claudication. Quite often, this disease actually progresses to a critical limb ischemia where the wound, the leg is at risk. The patient may present with a non-healing ulcer, with a severe rest pain, or an impending gangrene or an established gangrene. And many a times it is also complicated with acute limb ischemia, which is a typical cold limb, acutely cold limb, which requires immediate revascularization or amputation. So one has to prevent a limb loss, one has to prevent deaths from stroke, myocardial infarction, renal failure, and heart attacks, because this disease is only one, it is affecting the limb, but it is also associated with similar disease in the heart, circulation of the heart, brain, eyes, kidneys, and lower limbs. So if you see a patient of peripheral arterial disease, it is a big, warning, or it is a big reminder to you that look for disease in the other organs, and the patient typically is a vasculopath. So again, as I told you, PAD confers higher risk of amputation because of acute limb ischemia, because of chronic limb-threatening ischemia. It has much higher major adverse cardiovascular events, that means combined risk of death, acute myocardial infarction, and stroke, and major adverse limb events, which include amputation, and unless the patient has an immediate revascularization of the lower limb. I will be discussing and talking about and showing you some cases in the 10 or 15 minutes which I have. Now, how do you diagnose it? Typically, a classical presentation is claudication, that is aching, burning, cramping, discomfort, or fatigue of the leg on walking. And the location could be in buttock, thigh, calf, or ankle. And actually, if you look at it, if you take a good history, you can actually know where is the site of obstruction. So if you have an obstruction in the aortic bifurcation or in the common iliac arteries, you have a buttock claudication. If you have a blockage in the external iliac arteries, you will have a thigh claudication. If you have a blockage in the superficial femoral artery, you will have claudication in the calf. And if you have below knee arteries which are involved, you will have ankle claudication. So this is very typical. A good history can actually give you the site of the arterial obstruction. Again, when we talk about claudication, we talk about 2 or 3 things. One is, what are the symptoms of claudication? It could be just ache, burning, cramping, discomfort, or fatigue. We also talk about claudication distance. That means to what distance a patient can walk before he starts having these symptoms. And this is very important to actually know the severity of the disease, as well as to know the response to the treatment. So if you have a patient who actually can walk 100 meters and has pain, and if you put him into aggressive lifestyle modification and medical treatment, this patient actually, if he starts walking 500 meters or a kilometer without pain, you know definitely that the therapy is working, and there are good collaterals which are developing. Now again, it's very important to differentiate a claudication from ischemic rest pain, because if a person is having pain at rest, then this is the most severe form of claudication, and this means that the patient, unless intervened by medicine or surgery or intervention, this patient can actually lose the limb. And this requires an immediate transfer to a higher center where this patient can be revascularized and the limb can be saved. Again, some patients may not have pain, or may have pain associated with non-healing ulcer, or a non-healing ulcer without pain, and this is again a manifestation of critical limb ischemia because of severe peripheral vascular disease. And if you have such a patient, it's very important to see where is this, why is the wound not healing, whether the patient has a diabetic foot, whether there is a neurological complication or an infection or ischemia, and we actually need to correct all of them. Again, if the patient has a history of erectile dysfunction, this actually precedes even claudication and coronary artery disease. And if you have a history of erectile dysfunction in a male, and if the patient has, abnormal ABIs along with this, then definitely this patient has a polyvascular angiopathy, and this patient requires a complete evaluation of not only the peripheral arteries, but also for the arteries of the heart and brain. Now, how do you, when you have a patient who comes with either a pain on walking, rest pain, non-healing ulcer, or erectile dysfunction, in this, or an abnormal ABI, how do you approach this patient? So you take a good history, I've already told you, then this is followed by a good physical examination. Of course, what is very important and what most of us don't do in general is to palpate pulses in all the 4 limbs. So that is very important. You must palpate and auscultate pulses in all the 4 limbs, including and also carotid arteries. Auscultate also for the presence of bruit. So you may have absent pulses, decreased pulses, so you know that there is a disease. If there is a bruit, especially in the carotid arteries, you know there is a block there. Look for signs of ischemia, acute or chronic, in the lower limb. So if you have, loss of hair growth, you have, poor capillary return in these patients, you have nail bed changes, and if you have muscular atrophy associated with pallor or cyanosis, you know that this patient has a chronic ischemia. Now, third comes a very important test which is available to everybody in every clinic is ABI, which we forget to do. And ABI is nothing, it is just measuring the blood systolic pressure in the arm and measuring the systolic pressure in the lower limbs. And what we do here is we take a ratio of the systolic pressure in the arm and upon the systolic pressure in the lower limb. And either vice versa, the lower limb upon arm, and we derive an index called ankle brachial index. The normal value is 0.9 and above, so 0.9 to 1.1. If you have a value above 1.1, it means that these arteries are non-compressible and there is a calcification in peripheral arteries. And if you have a value less than 0.9, it means there are blockages in peripheral arteries. And then again, you classify them into 3 categories. If it is 0.7 to 0.9, it is a mild form of peripheral vascular disease. 0.5 to 0.7 is severe, and anything less than 0.5 is a very critical form of peripheral arterial disease. Sometimes, what we do is we may have sophisticated instruments like a pulse Doppler for measurement of ABIs, but we can actually do ABIs by just auscultation and palpation. We actually, with the help of integrase, we did a sort of testing and comparing whether pulse Doppler is actually necessary and whether it correlates with the ankle brachial pressure measurement by auscultation, palpation, and with vis-a-vis, with arterial handheld Doppler. And what we found out that both are technically and practically equivalent. So you necessarily do not require a handheld Doppler to do an ABI testing. Just an auscultatory and palpatory method is good enough, except in cases where the pulse is not palpable. So if the pulse is not palpable, which is like, say, in 10% of cases, in 90% of them, you can actually do an ABI in your clinic and diagnose this presence of peripheral arterial disease in these patients. And not only peripheral arterial disease, you also diagnose the presence or the higher incidence of coronary artery disease, of carotid artery disease in these patients. So, as I told you, 3 clinical testing, good history, good physical examination, and ABI. These 3 tests are going to pick up at least 90% of patients with not only peripheral artery disease but also atherosclerotic vascular disease anywhere in the body. So this is very important, and I must again congratulate integrase to actually coming out with this idea and actually doing this testing, comparing handheld Doppler ABI measurements with, ABI measurements with palpation and auscultations. We have a data of about 1,000 patients, which we are going to publish very soon. And also, we did this in a camp setting, and then this was one of the bench tests, and how to pick up the disease. I'm going to talk about it, how in camp settings we picked up diseases in asymptomatic patients, and how we could save many lives just because of this simple test. Also, integrase has come out with a major contribution to medical fraternity by organizing these vascular camps where we not only look at the risk factors of coronary artery disease or peripheral vascular disease, but we also do ABIs in the clinics which are free of cost. And because of this, we have two goals. One is to get the prevalence of peripheral arterial disease and atherosclerotic vascular disease in our country, which the data which we don't have as of now in a large number of patients. Secondly, it also helps us to correlate the risk factors with the prevalence of disease in different geographical areas of the country, and also how to correlate the presence of CAD and cerebrovascular disease with peripheral arterial disease in our country. So this is a great study. This is a great contribution, and these camps are done free of cost. Now, how do you manage? That's the third thing. Once you know there is a peripheral arterial disease, which can vary from asymptomatic stage to a stage of where you're losing your limb and life, there are different ways we treat it. The first one is to control the risk factors. The biggest risk factor is control of smoking. So no smoking, no tobacco, that's the first thing. Very good control of your diabetes, lipids, blood pressure, as well as lipids, and as well as the risk factors like taking of some drugs, which are especially important in younger age group where people are taking recreational drugs, and those are the causes of sudden acceleration of peripheral arterial disease. So conventional risk factors control is first step. The second step is walking. So if you keep walking, you stop smoking, you take control of your risk factors, which are the conventional risk factors for atherosclerotic cardiovascular disease, you actually start developing good collaterals, you arrest the progression of the disease, and you can save many of these patients and follow them up by history, looking at the claudication distance and improvement in the ABIs. Now, second is the medication, and of course the medication is in two groups. One is medications for the risk factors, that means for control of diabetes, lipids, and blood pressure. And second are the medication where you actually work on improving the blood supply to the lower limb as well as dilating the blood vessels and preventing thrombotic events. Here comes the role of antiplatelet drugs as well as anticoagulant drugs. So now we have very potent and very selective antiplatelet drugs. The most important one is cilostazol, I'll be talking about it, and also the role of dual pathway inhibition in peripheral arterial disease. Again, structured exercise program, as I told you, is very important, and we have experts here. If you have diabetes and if you have a diabetic foot, then a good control of diabetes, a good preventive foot care is very important, whether done by an ankle surgeon or a foot surgeon or by a podiatrist or a combination of cardiologist, endocrinologist, and physiotherapist. It is a very important as a cornerstone of therapy in peripheral arterial disease. Now again, I'm not going to go in details. Let me just give you what we have in lipid-lowering therapy. It has, if you have peripheral arterial disease, you have a class 1 indication to give statins. And the dose of it is, if you have a PAD, which is manifest in form of severe claudication, rest pain, or a non-healing ulcer, or a previous history of an interventions for peripheral arterial disease or coronary artery disease, or stroke, in this situation, you have to give aggressive lipid-lowering therapy. And here, your LDL goal should be less than 70 mg/% as per the latest guidelines, which are the ESC, AHA guidelines, as well as Lipid Association of India guidelines. Again, the blood pressure control has to be less than 140/90, ideally around 120 to 130 by 80 to 85. And it is recommended that also test for lipoprotein little a, which is an extended lipid profile measurement, If your LPA is low, if your LPA is high and if your homocysteine levels are high, these are the two things which we do apart from HSCRP, which is a marker of vascular inflammation. If these are high, then you add drugs like folate and vitamin B12, and you also increase the dose of statins in these patients so that we reduce vascular inflammation in these patients. Sometimes even colchicine is a very important drug to be given in these patients. Now again, the gist I've already given you regarding the medical therapy in patients of peripheral arterial disease. Again, what is very important is the foot care, and as I told you, the foot is ischemic and it may present with non-healing ulcers and infection, or the patient has a little injury and has a diabetic foot. Now, whenever we are talking about diabetic foot, what we just in general think that we control the diabetes, that means the blood sugar, and we give revascularize, the foot is going to be okay. But that's not true, because the diabetic foot has four components. It has a component of ischemia, it has a component of infection, it has a component of neuropathy, and it has a component of orthopedic issues. Because of abnormal weight transmission, there is a joint issue. All four have to be addressed, otherwise you will keep having recurrence, repeated injuries, and you will not be able to properly take care of diabetic foot. And of course, it requires a good foot care and a good, toe pressure measurements to actually give a good foot insole to these patients. Now, in terms of medications, as I told you, you have different drugs, antiplatelet drugs, which are very important. The two drugs which are very important are silestazole, because silestazole is the most effective antiplatelet for the lower limb. It is a very potent drug to control or to vasodilate the lower limb arteries, so that it controls, it improves the ischemia because it has a vasodilatory effect. It's a phosphodiesterase inhibitor apart from being an antiplatelet drug. And also it prevents arterial thrombosis by preventing platelet adhesion and platelet aggregation. Initially we used to use pentoxifylline, but as of now it's not recommended, because what pentoxifylline does is only it deforms the RBC so that they can go into through a stenosed capillaries, but it's not the drug of choice these days. But what is important is the role of low dose direct acting anticoagulants like rivaroxaban. There have been two famous trials. The most important is the COMPASS trial, which has two arms, the CAD arm and the PAD arm. The COMPASS trial actually looked at patients who had atherosclerosis and peripheral arterial disease. And what they saw in these patients, not only there is ischemia because of stenosis, but there is also ischemia because of recurrent thrombosis, a fact which we know. Many of our CLI patients actually have ALI as an acute presentation, because when the flow is sluggish, there are more platelet aggregation, but there is also an activation of coagulation cascade. So we need to actually give two types of drugs, which are antiplatelet and also which are anticoagulants. We call this therapy as a dual pathway inhibition. So from SAPT or DAPT, the therapy has now shifted to DPI, which is the dual pathway inhibition. So what we do here is we give 2.5 milligram or 5 milligram twice daily of rivaroxaban and add an antiplatelet drug, most likely silestazole, and treat these patients who have severe peripheral arterial disease. It's been seen in COMPASS trial, which is one of the biggest trials done on these patients, that patients with stable peripheral arterial disease and coronary artery disease actually do as well as patients who undergo treatment by angioplasty or bypasses. Again, one has to understand that once we are doing this, there is also a role of newer drugs like inclisiran, where you cannot achieve goals by statins, or where the statins cannot be tolerated because of side effects. Now we have targeted molecular therapies like inclisiran, which are messenger small RNA therapies, which you only give twice a year, and you can bring down the lipids and LDLs to a very low level. Now, just what are the takeaways from the presentation which I made? That PAD is very common. The prevalence is about 236 million people globally. The risk factors are conventional risk factors for atherosclerosis. PAD is, and also smoking, the PAD is associated with major adverse cardiovascular events, and that is combination of strokes, MI, and death, and limb loss. And the evaluation requires a good history, good physical examination, and definite measurements of ABI. And the treatment has to be guideline-mediated medical therapy. And here, cilostazol and dual pathway inhibitors are very important. Now, this is the medical part which I wanted to convey. Let me just show you 3 cases where and how we treat peripheral arterial disease, because the whole seminar is on PAD. Let me start with one of our camps where we actually validated the handheld Doppler with measurements of ABI by manual and auscultatory method. So we work in an organization with Kripaluji Maharaj. We have 3 hospitals, more than 200 beds. We have about 100 doctors, and we treat almost 2,000 patients every day free of cost. Our facilities in these centers include 256 slide CT scan, 2 high-hand echo machines, Affinity 70, the state-of-art biochemistry labs and hematology labs, apart from many other things which we have. Now, this is a camp where we saw about 700 patients. These were screened patients from rural setting, which came to us on those 2 days. All these patients had all the biochemical profiles, risk factor analysis, ABIs done both by handheld Doppler and the conventional method of palpation and auscultation. And we collated this data just to validate and also see the prevalence in rural setting. This was probably our first camp which led to these PAD clinics by Integrace. And you have seen this PAD clinic workup outside this hall. And what is very interesting, you can see that in Indian context, they have almost done in the entire country, different region. And what is very surprising is the females outscoring, the incidence of PADs in females outscoring that of males, and the incidence of PAD actually increasing, being much more common in younger age as compared to older age. And this is typically the same pattern which we also see in coronary artery disease. Now let me show you 2-3 cases. Now this is a 54-year-old diabetic hypertensive male who's a smoker, had a bypass, coronary artery bypass grafting, and this patient presented with claudication. He had no ulcer, no gangrene, an ABI of 0.8, and a CT. And again, if you look at it, this patient has coronary artery disease, has a mild, derangement of ABIs. That means the PAD is not very severe, and there is no sign of resting pain, or there is no sign of impending gangrene. Again, when you did a CT angio, we found that there is a diffuse 50 to 70% iliac stenosis, and you had 2 vessel Renault below the knee. So again, I just want to show this patient because we do not go with an idea that every block in the peripheral artery requires an intervention by bypass or surgery or by angioplasty or stent. So here we had all the options: surgery, endovascular intervention, stem cell therapy, gene therapy, hyperbaric oxygen, and optimization of medical therapy. So these are the 6 things which we do for treating peripheral arterial disease, and of this, we clearly know that this patient was the right candidate for optimized medical therapy and lifestyle modification. So we asked the patient to stop smoking, to put him on antiplatelet therapy and low-dose rivaroxaban. We controlled the lipids to the right targets. We gave antihypertensive therapy and had a good glycemic control. So this was the ABI in this patient. If you look at it, the plethysmography, and I'll just forget this. Now, then we had a second patient where if you look at this angiogram, this patient actually had a very bad ABI, and if you look at it, this patient had an occlusion of right common femoral artery, you see. Then if you look at it, this patient had a high-grade stenosis in the right superficial femoral artery, and therefore this was associated with total occlusion of the popliteal artery and a poor below knee disease or a runoff. So I think it's playing. So you can see there's hardly any runoff. There is a chronic total occlusion of the lower limb vessels and very poor supply in the lower limb. Now this patient presented with rest pain as well as a non-healing ulcer. And I'm just going to skip through this. These patients were initially candidates for amputation and probably a high-level amputation. Nowadays, we don't do this with the help of, we don't even do bypass for these patients. Now, this is a technique of subintimal angioplasty, which we are doing. And this is followed by balloon dilatation. I'm going to skip because of paucity of time. We do a subintimal angioplasty. We dilate with the balloon. We use intravascular lithotripsy to actually break the calcium. Then we do an intravascular ultrasound to actually get into the true lumen back after we do subintimal angioplasty. And then we do treat these patients, as I told you, with shockwave lithotripsy. As we break the renal stones, we break the calcium in these vessels, and then go ahead and do stenting of the popliteal artery. We have dedicated stents now to actually be put in flexing joints, over the flexing joints, and then we do complete the procedure by drug-coated balloons. So this is what we get in the end. So as you see, we can open the femoral artery, we have opened the popliteal artery, we have got a good supply in the below knee vessels. We had 3 vessel runoff. And this patient, you can see the flow in the foot has improved a lot, and this patient then was given to care of a good podiatrist, which included an orthopedic surgeon and also a plastic surgeon. And this patient healed his wounds, did not require an amputation, and mind you, this patient was 97-year-old. He could walk on his own without any problems. So these things are possible. So this case shows you, a combination of subintimal angioplasty, intravascular lithotripsy, drug-coated balloon, and at the end, restoration of palpable pulse, and also a good ABI at the end of 0.95. This is just an overview of the technologies which we use for revascularization. They are fairly advanced. Whatever we are doing in coronaries, we have much more technologies in the peripheral vasculature, which include balloons, cutting balloons, drug-coated balloons, drug delivery balloons, atherectomy devices, devices dedicated for subintimal entry, devices dedicated to do tibial angioplasty and below the ankle angioplasties, laser atherectomy devices like laser rotablator, and optical atherectomies. So everything is available. Again, I'll come back to our own camp, as sometimes the disease is not at all showing any symptoms. We had a patient, and in our series of 700 patients which we screened, we had 5 patients where we could diagnose peripheral artery disease just based on an ABI and good history an examination when the patient did not have any symptoms. And based on this, we actually worked these patients up, and we have 5 patients of severe coronary artery disease, which we could save by timely interventions, and of course, we could treat the peripheral arterial disease. Let me give example of one patient. This patient had an ABI of 0.7. When we further evaluated, he was a diabetic patient, did not have any pain. We found that he had a tight stenosis. We did a CT angiogram there. He had a tight stenosis of the mid part of left anterior descending artery. Secondly, this patient, the only symptom he had was knee pain, which was thought because of osteoarthritis. He did not want surgery, and what we did was we did a geniculate artery embolization to take care of his osteoarthritic pain. Then when we looked at his peripheral arteries, he had a very severe form of below knee disease, and also disease in the ankle. And what we did is we restored the blood supply through the pedal punctures, and we opened the tibioperoneal trunk, and this was then followed by a reconstruction of the plantar arch, and we could restore blood supply to the foot, and this patient, actually we could save him of a future problem. Again, when we further tested this patient, then the patient told that only symptom he has was the pain because of arthritis, and because of that he was not walking, and because of that he was not having claudication pain or angina. So some patients who are restricted just by osteoarthritis and who are diabetic may not have any symptoms. The only clue is to do an ABI. If you have a very abnormal ABI, you start looking for this disease, as is shown in this patient in our camp which we did. And here we could save this patient from a heart attack by an angioplasty. We could save the limb by a good below knee angioplasty. And we could also, he had the other symptom which he had was impotence, and we did his pudendal artery angiography, which you can see. We could open his pudendal artery and actually treat this patient and treat him also for impotence. So this is the pre-lesion before, this is the angioplasty procedure, and this is after dilatation. This is a stent being placed, and this is the stent being deployed, and this is the final result which we got. So I've just added this to our series of pudendal artery stenting which we have done. Till now we have done about 32 cases where we did just balloon angioplasty in 11, put drug-eluting stents in 21 patients. We had clinical success in 31 patients. And this is a follow-up of our patients where we see there are no deaths, perianal or penile gangrene, and the technical success is 100%. What we see is also there is a good success in terms of objectivity as well as subjectivity, not only that the patient has improvement in the erectile function and impotence, and the patient, this is also correlated with improvement in the penile velocity as per the penile Doppler. So I will stop here. If there's any question, I'll ask, and I'll leave this to the further speakers to be addressing the other part of peripheral vascular disease and joint problems in lower limb. Thank you. So if there is a question, I'll be happy to answer because I have a flight back to Delhi.
For creating an awareness. Is it available in our place in Tamil Nadu?
I mean, the screening part or the... yeah, of course, in Tamil Nadu, there are good vascular surgeons, there are good cardiologists, and maybe some radiologists who are practicing this. And I know that we have a good setup in Apollo, we have a good setup in Madras Medical Mission, and maybe many more centers which I don't know. But I think what is very important is a team approach where cardiologists who specialize into this, radiologists and vascular surgeons and diabetologists and orthopedic surgeons, plastic surgeons, and general physicians, they all get into a group, diagnose this disease, treat medically or by intervention or surgery whenever required. And awareness is the most important thing which we want to create.
One important aspect that you mentioned in your treatment part, geniculate artery embolization, is it being done in many patients for just pain alone?
Yeah, so I can tell you what we do in our hospital in Delhi. So geniculate artery embolization works on two principles. One, that if you look at osteoarthritis, there is an inflammation, and this inflammation actually leads to more arthritis. So if in an inflamed area, if you can reduce the blood supply, the pain actually, the progression of the osteoarthritis and the inflammation reduces. Where we do it in only two conditions because the patients are referred to us by the orthopedic surgeons. One, if they have pain post, total knee replacement. Or second, if the patient does not want a knee replacement and he is in chronic pain, he is not responding to steroids, he is not responding to anything, or he has contraindications to anti-inflammatories, then that is the subset where we get referrals from orthopedic surgeons. We have an experience as of now, maybe for 20, 30 cases. I don't know exact number, but somewhere between these two. And the patients do subjectively say that they are relieved of the pain in majority of the cases. But it is not that the patient is off pain as soon as you do it. It takes a little time for them to get out of the pain or to reduce their pain.
But do you face any other complication after embolization?
No, we don't, because I think I did not show you how we do it. We actually go and first map which arteries are the culprit. So an artery, we do a super selective angio, the one which causes the maximum blush and into the synovial membrane. That is the artery which we embolize, and we embolize as distally as possible. We never do more than one or two arteries in one sitting, and usually those are enough. So we are not doing a non-target embolization. We are doing a super selective angio and a highly targeted embolization. And normally we use either PVA particles or embolospheres. So these are very minute capillary level embolizations.
And what will be the cost of the procedure for lower limb artery stenting and after this procedure?
The cost?
Cost.
It depends. Sometimes depends on two things. One is the amount of hardware which you use, and also the institution where you are practicing. And again, the hardware if you use, like in our institution, the cost is little more because we don't reuse anything. But in most of the institutions, they do re-sterilization of, and they use the same devices in many patients. The cost is not high, and it's almost similar to a coronary angioplasty. I think in a government setup, it will be around 1.5 to 2 lakhs. In our center, it will be almost twice, or maybe a little more than twice the cost.
What will be the take for pudendal artery recanalization for impotence and sexual dysfunction?
I didn't get your question.
What will be the take for the patients and other setups for pudendal artery recanalization?
So pudendal artery stenting, again, I've not gone to the detail. It's not that every pudendal artery needs stenting or will improve. If you look at impotence in general, how we work up, first we root out the psychological cause. That's the most important. We will filter more than 80% in that setting. Then we send the patients to urologist or vice versa. They send it to us. He has a good endocrinal, psychological, and urological workup. If these patients are okay there, then what we do is these patients are invariably given Viagra, or they are already taken Viagra or similar drugs. Now, where we do pudendal artery stenting is complex ED. The complex ED is defined patients who fail Viagra therapy or phosphodiesterase PGE5 inhibitor therapies. In those patients, then we subject them to penile Dopplers. And the penile Doppler is done by giving intracavernosous injection of papaverine. So only few doctors in Delhi, at least I know, are trained to do a good penile Doppler. And once we do a penile Doppler in this way, if your peak systolic penile velocity is less than 25 centimeter per second, that means these patients probably have an inflow problem. Now, because the vascular problems could be an inflow problem, or it could be, the more common one is a venous leak, where the blood supply inflow is good, but the outflow, there is no resistance. So that is the other way we tackle is by embolization of the venous outflow. So once we have this, then we subject these patients to selective angiography. Now the inflow problem can come from aortic bifurcation like in Leydig syndrome to external, to common iliac obstruction or stenosis to the internal iliac artery stenosis all the way up to the penile artery, or to the pudendal artery. So the pudendal artery is a direct extension of the anterior branch of the internal iliac artery. So in entire path, the obstruction could be anywhere, and wherever is the obstruction, we first treat that. Most of the times, the obstruction is in the pudendal artery itself. Now, if you have to look at the pudendal artery, it is one of the longest arteries, and it is a sleeping artery. Again, like we do an intracavernous injection of papaverine, we need to wake this artery up, and we need to give intrapudendal artery vasodilators to actually see and delineate whether there is a true stenosis or not. If there is, then we go ahead and treat by either a drug-coated balloon or a drug-eluting stent.
So in that case, what will be the cost?
The cost is same as coronary. We are not doing anything different. It is the same as any other angioplasty. So, I mean, if it is a government setup, there is no cost for the procedure or the bed. It's only the hardware, which are also subsidized. If it is a private setup, cost addition is because of the doctor, because of the procedure, hospital, and the bed. So that's how it is. So there is no additional cost. These are simple angioplasty procedures, but the more important thing is, if you really want effective results, you have to screen the patients in this way. Not every stenosis is the cause for erectile dysfunction, and patients may have other causes which are more important.
One more question for peripheral artery disease itself. Because you have chosen phosphodiesterase inhibitors, what about other phosphodiesterase inhibitors that are available in the...
For peripheral arterial disease, we can use them also.
Like
we can use them, but I was mentioning that in reference to antiplatelet drugs. Silestazole is the only drug which has an additional property of being a phosphodiesterase inhibitor and vasodilating arteries, especially in peripheries. So initially when silestazole came, it actually came as a drug for symptomatic treatment of claudication. Then it was also found that it's a good antiplatelet drug. And now, the recent trends are that now the neurologists are also using it for, neuropathic pains and neuropathies without pain also. And the rheumatologists are also using it in patients of arterial inflammation, SLEs and vasculitis. So this is the drug which is finding newer, uses apart from just claudication.
Is there any comparative study of using other phosphodiesterase inhibitors?
No, there is no contraindication, but because it has a dual advantage of being an antiplatelet and phosphodiesterase inhibitor, it is being used.
Thank you. Thank you.
Thank you, sir. I have 3 quick questions from the doctors who have joined online across India. So I'll just name. This is Dr. Shubha Aditya. He is from Kolkata and he's a general surgeon. He wants to know what should be the routine dose of rivaroxaban.
So routine dose of rivaroxaban would be a low dose if you are using it in combination with antiplatelet. It has to be somewhere between 2.5 to 5 milligram, not more than that.
Okay, thank you. Then silestazole is in ischemic cerebrovascular disease. Is it used? I believe you just mentioned, but...
Ischemic for peripheral neuropathy, yes, but for stroke, I'm not too sure whether it's being used. I don't think the neurologists are using it for stroke.
And this is from Jharkhand, Dr. Tahir Hussain, and he is asking us about silistazole. Can it be given in varicose veins?
No. See, varicose vein, I don't think any drug helps. Varicose vein are a mechanical problem because of failure of valves either at saphenofemoral junction or saphenopopliteal junction or at perforator level. What helps is a mechanical solution to this. The simplest solution is to have compression stockings, which will not allow the blood to, reflux into the superficial veins. The other thing is to ablate the veins or remove the veins, either surgically or to destroy the veins by RF energy or laser energy, or just block them off by a glue. So it is a mechanical problem. It needs a mechanical solution. And just like the orthopedic surgeons, you also would be knowing, a mechanical problem needs a mechanical treatment.
Right. So last question from Dr. Nagendra from Bangalore. He is asking about should he start with 50 or 100 for silistazole therapy, and this is with regards to the dosage of silistazole.
Again, it depends. Normally we start with 50 if the patient is having some other antiplatelet drug, but eventually the patients end up with, receiving 100, at least 100 milligram a day. The only thing you have to be careful, don't give silistazole in patients who have heart failure. This is one drug which is contraindicated in heart failure, apart from being contraindicated in pregnancy.
I am Dr. Bhaktavachalam, consultant vascular surgeon. Because you said 33 cases of pudendal artery stenting and this thing. We usually treat Lerich syndrome with the iliac disease. We usually concentrate more on establishing the blood flow to the external iliac artery. We ignore internal iliac artery. If there is any stenosis, how many cases isolated pudendal artery stenosis you have seen in the 33?
So this is our series of isolated pudendal artery stenosis. This is not, these 32 cases are only pudendal artery stenosis, not all cases of inflow problems which we have treated. So this is, again, as I was talking to Dr. Simon, it is a part, now we have about 50 cases, 53 cases, but these 32 cases we have published, and this was the largest series in the world which was published for isolated pudendal artery stenosis causing impotence and getting treated and with a good result. So if you're really, it's not a huge number, although the problem is huge, but the amount of number of patients who come to us after all this filtration and actually want a treatment is this. Again, like peripheral vascular disease, erectile dysfunction is a very common problem. It's estimated that after 50 years of age, at least 40% of people in US have different degrees of erectile dysfunction. And what is more important, it predates manifest coronary artery disease by 5 years. If you have a impotence or erectile dysfunction, and it actually is a warning symptom or a warning sign to look for coronary artery disease and treat it before it really comes as a acute coronary syndrome. So that is a very important corollary from this. But people tend to ignore, and people think it's because of depression or beta blockers or whatever. But it is a very common problem, and it should be, unless you ask, patient will not tell. And sometimes the doctors are embarrassed to ask. So much so, even if you are giving beta blockers, we don't even tend to ask patients who have a side effect of the drug which can cause this, still we don't ask.
Thank you, sir, for this thing. You have asked whether this peripheral vascular disease, endovascular procedures are done in Tamil Nadu or not. The Tamil Nadu, we are having the most number of vascular surgeons in all, compared to all over the India. We have very good centers. All the government medical colleges now are having a vascular surgery department. Vascular surgery PGs, cath lab is available. All the procedures, we are the pioneer and we are leading peripheral vascular disease in Tamil Nadu. I am Dr. Bhaktavachalam, former HOD of Omandurar Government Medical College. Thank you, sir. Thank you.
So thank you, sir. Thank you very much for your presentation. And I hope you don't have to wait for the next flight. And he has a flight, so please have a safe journey back home. Thank you very much once again. So I have the next speaker with me, and this is Professor Dr. Jay Lal. And sir is going to talk about the espresso, the silistazole. May I have his laptop, please? Can you connect?
Drug silastazole and how it is going to act and what are the indications and what are the complications for that. We coined the term, it's an espresso shot for the peripheral arterial disease. We all know that is the espresso coffee we often used to take when you are tired and when you are much worried, because it's an instant energy it gives, the rise in the antioxidants it gives. It's a mental happiness which gives, and some of you who have taken this espresso coffee that you know that important that. And similarly, silastazole is a drug which is being a dual effect. It not only produces the blood vessel vasodilatation, but also it is a power of making the platelet unsticking with each other, thereby preventing the thrombosis and the clogging of the water. So you make the vessel in which it carries, it dilate and prevent all the blockage. So it helps in that way. And we all know that diabetes, and the previous speaker also very well explained, and it is a combination of the multiple reasons. And you cannot treat a peripheral arterial disease with a diabetic food on a single mode of operation. It is a multiple way, the neuropathy and vasculopathy. One of the most important thing, many times we think it is a sensory neuropathy is the main reason, but not only the sensory neuropathy, the motor neuropathy, which is resulting in the clawing of the foot, that is also going to lead a problem. But most importantly, the autonomic neuropathy. The autonomic neuropathy plays a major role here because it talks on the microvascular supply of that. It is a AV malformations which are taking place, and how the cutaneous ischemia which has been there, all this plays major role by the autonomic neuropathy. So that way the microangiopathy part is there, but equally the macroangiopathy part, the peripheral vessels or itself is affected, especially when you talk about the peripheral arterial disease and association with the diabetic foot. And the people who have diabetic foot, almost 40 to 70% of the people are having peripheral arterial disease. And once this combination and peripheral arterial disease with a diabetic foot ulcer is developing, and that is a deadly complication because it is going to result in the healing, and the mortality is also high. And there is also difference when somebody is having a non-diabetic fellow developing peripheral arterial disease and a person who has a diabetes developing a peripheral arterial disease. And the atherosclerosis, which we commonly say for the peripheral arterial disease, which is going to develop in a person who has a diabetic, much aged, almost 15 to 20 years much younger than a normal person who is not without the atherosclerosis developing. And often in diabetes, it is a severe, it is not a focal and particular place, and it is most of the time it goes asymptomatic, and that is what we say, because we all know that diabetic people can have a chest pain without any real pain because they have an autonomic neuropathy. So patient may not have the typical claudication pain, but still he may have the peripheral arterial disease, so we may miss that. And most importantly, if you see atherosclerosis, it is always the intimal sclerosis, but here it is producing the medial sclerosis, or we have Mangiberg sclerosis, and that makes the vessels also non-pliable. It will not be able to move around. The dilatation and the vessel glowing is not affected. So that results in, and one of these, the previous speaker was very much putting on the angle brachial index. But in a case with the PAD with the diabetes, even the angle brachial index can mislead us, because these vessels, because of the calcification or the medial calcinosis, it may show a normal angle brachial index or even exaggerated angle brachial index. And instead of what we normally get in a peripheral arterial disease, the low angle brachial index. So in those cases, the toe pressure is the most important thing to see. It is not only the neuropathy and the vasculopathy, but also it takes on the intimal level, cells level, whether the vascular cells, the endothelial cells, the smooth muscle cells of the vessels, and all these have an impact. And especially in the inflammatory markers, the platelet, when it going for the lacy platelet, the chemostaxis is affected. There's so much of things are changing in place. So when you want to treat a peripheral arterial disease and the diabetic foot, you need to be a little more careful on that. A lot of studies, and the previous speaker has very well explained, the peripheral arterial disease, the silestosol plays a major role. And whether international studies also prove that. And whenever a patient have, particularly with the peripheral arterial disease, there is a lot of studies has shown, and the silestosol is going to be a helpful things to that. When the American Diabetic Association, and it also says when the patient is having a diabetic foot and PAD, and the two drugs they recommend, one is aspirin. Aspirin is recommended for any PAD, and which is going to help with the COX-2 inhibitor, which is going to help the secondary complications of the PAD, which are associated with the cardiac diseases and cardiac impact. It is going to do that. But it has no role on not much role in the diabetic foot healing. But phosphodiesterase, the silestosol, because it is going to perform the vasodilatation in addition to the inhibition of the platelet aggregation, it is playing a role in that. And that is why even the American guidelines which states that the role of silestosol in the effective therapy in the improvement of this. And how this is going to work. And this is most importantly, we should know that how the phosphodiesterase help in the diabetic people. And it has a lot of mechanisms. We always know it is a nitric acid is playing a major role, and silestosol helps in improving the nitric acid. It also has a role on the lipid modifying effect. Especially the triglyceride level is less, and the high density lipoprotein level it is increasing. It has already, we have explained about the antiplatelet effect, and it has an anti-inflammatory effect, because now vascular inflammatory markers are playing a major role in atherosclerosis and the vascular impairment. But the drug and phosphodiesterase inhibitors, it is playing a major role in anti-inflammatory effect. It helps in the protection of the endothelium. It helps preventing the anti-proliferative effect, especially as we saw in the previous slide, the smooth muscle proliferation in the vascular level and the endothelial proliferation of the muscle, which also can add onto the blockage, and this helps in the prevention of the proliferation. So collectively, it helps in all the sectors, and the way the drug is working on, it is anti-platelet and vasodilator effect. Platelet aggregation, it is reducing. It increases the cyclic AMP levels in the cells, in the platelets, and thereby it helps in the smooth muscle activation. It improves the walking distance. Having this in mind, and we wanted to do a study on how it is going to help on the diabetic foot patients. And the standard drug which was used is typically 100 milligram taken twice daily, and it takes minimum 1 to 3 months for the effect for that. And wound healing, and that is our priority in a diabetic foot ulcer, because unless we do the wound healing, the complication is going to be very deadly. So a lot of studies has been done, especially a study which has been very recently published in the Annals of Vascular Surgery, which says there's effective role of the silestosol in arterial healing. This is a study we did in our college with using for the same patients a set of people with the diabetic foot, a group having only aspirin, and another set of people who having an aspirin and silestosol. And whenever there were the patients whom we did a study with both silestosol and aspirin, we could see the faster wound healing and reduced the inflammatory markers, and the response of the treatment is much quicker, and very good impairment which we are seeing. Because many times we do not use this silestosol in the fear of the complication, which I will come to that. And the silestosol study has been done by the various other papers controlled trial also, it is proved. And whenever you are giving this drug, the slow progress and the growth we are going to get is very great. So it has a potential vasodilator effect, which we have already discussed on that. And what are the adverse effects? The silestosol, and why it is there? Because one of the back of the mind with any clinician we ask, whenever we say, when the patient has a cardiac disease, especially the congestive cardiac failure, the silestosol cannot be used because it increases the heart rate, and that definitely it is the effect. So that is the one in the back of the mind. So most of the time, whenever you have the congestive cardiac failure, which is a demonstrated, and patient patient having a difficulty, then definitely it is been not advisable to that. And previously there was a question asked, the cerebral ischemia can be used? Absolutely, there is a lot of study, especially the stroke prevention by the Celesticol study, which is done by the China, Taiwan and Asian countries, was well proved that when you are using, even for cerebral ischemia, but what we say is it produces vasodilatation. So even the cerebral vessels will go for a vasodilatation. That is the reason why one of the most important complication you get with the Celesticol is a headache. The headache is producing, it is also an indication that Celesticol can produce the microvascular and the vascular dilatation of the intracerebral arteries also. So that produces, that is one of the most common complication when you use Celesticol you will get. And other few complications are diarrhea, palpitations, the dizziness, but all this, once you stop the drug, and definitely all this will be come back. And this is a study which that. And a lot of other studies which has done, and how when the patient having a diabetic foot and a claudication, and when you are putting the patients on the Celesticol, it improves the walking distance for which they're going. It improves in the speed and how the patient is able to climb in the stores. It will also improve with the Celesticol. That's one of the most important study which comes with that is called Castle study. It is a Celesticol study on the long-term effect. This was a study which is done on the patients to see that how it is going to improve the effect of the it has more than 1,500 patients were included in the study, and it has proved very well the concomitant use of aspirin and clopidogrel, that is good, it was proved, but it is also shown the most importantly the other group of people, when the people who are going to get a Celesticol and how their cardiac and cerebrovascular, the vasculature is been improved, how cerebrovascular performance is also improved. So it concluded, the Castle study has concluded approximately after the 1,400 people, and as we think it would not produce any cardiovascular morbidity, it do not produce any cardiovascular damage, but it also do not produce any increased bleeding in the case when you are using for the persons with the concomitant antiplatelet therapy. It also says it is a risk reduction in the benefit to the stroke population. That is what the previous question which we asked. So the intention of this, because we did a study and the study has been also reproved in a patient coming with a diabetic foot ulcer, and when you are concomitantly using along with the aspirin and or along if you are using Celesticol, it helps in the vasodilatation and helps in the prevention of the early healing of the patients. Next slide. Can you take? When a patient comes with a diabetic foot. And we all know the incidence of the diabetic foot and the number of people who are having the diabetes in our country. And we call it India is a capital of diabetes. And they almost 14% of our population in Tamil Nadu is having the diabetic or people, and equal number of 14% of the people are having a pre-diabetic people. The most important slide I just want to think, and whenever we talk about the diabetes per se, the complication of diabetes, we always think in terms of the cerebrovascular incidence or the nephrogenic problem, renal kidney problem. But there's a lot of studies has proved, and once you have a diabetes for a long time, the most important cause or most important reason for which you are going to get admitted into an hospital is not your cardiac problem, but it is the limb problem, the diabetic foot problem or the PAD with an ischemia which you are going to develop. And if you see, it is a phenomenally increased percentage, more than 20% of the people with the diabetes is the most common complication. But I am much worried as a surgeon, what we normally take, we talk in terms of the cancer survival rate. We say in terms of 5 years survival. If you say a cancer is very disastrous cancer, if the survival rate is less than 50% for the 5 years. And now we have the treatment and much better treatment facilities. And most of the cancers which we can say, we have a 90% survival rate for 5 years and 70% survival rate. But unfortunately, and once you have a diabetic foot ulcer, and once you are that a small amount of local gangrene is going for an amputation, the possibility of you living for another 5 years is only 30%. And this is the most dreaded thing in which we are seeing that today, that the thousands and thousands of people are losing not only their limbs now, and if they lose their limb or lose their diabetic foot ulcer, and another 5 years, and only 25% or 30% person will be here to see this world. So that is a challenge, that is a thing which in front of us, and as a practicing doctor, whether it is a general practitioner or the surgeon, as we need to take care. And as we said in the earlier slide, that diabetic foot ulcer is caused by the multiple pathology, and equally we need to have a multi-way of treatment. And it's not that one way of treatment is going to help, whether starting from the debridement and starting from the how we are going to do, and vascular surgeries which we are going to do. I'm going to talk about one of the methods which we use commonly for a interface, which is is a negative pressure wound therapy method. And once you are using a negative pressure wound therapy technique, and if you send, it is one of the vital competency a diabetic foot surgeon or a general surgeon must learn to treat patients who are coming with a diabetic foot ulcer. Having back in the mind, and if I am not treating it appropriately, and if the patient is going to lose his limb, and his life is also going to be lost. So we need to take all the steps, and one of the most important steps is a negative wound therapy. And here there is a 3-4 principles are important, and that is not an alternative for any other treatment. But once you want to do the negative pressure, the first and foremost is in absolute debridement, and there is no way you are going to be kind with the diabetic foot, and you have to go and aggressive debridement. And second, the placement of the interface in an appropriate interface you are choosing, and approximately you are putting it on that, and at the correct parameters, and how you are going to do that, and how much the pressure you are going to maintain, how you are going to maintain the pressure. And my talk will be on how we are going to do the debridement, absolutely debridement. And this is what, and every surgeon who is going to be interested in the diabetic foot management, and as I had said earlier, the cold knife is the best way. And if the patient comes with the wound, absolutely you debride it to the maximum perfection. If there is coming with a pus, you can remove, and even if you are going to lose the small parts, it is okay. And now we use a lot of newer technology like a laser, larva therapy, the worms therapy, and we know that when the patient is coming with these worms inside the diabetic foot ulcer, that is always a good sign, because this will, all the necrotic tissue they will take away, and the wound you are going to get a well debrided tissue. The second most principle is what kind of interface for the negative wound therapy, and what type of interface you are having. Commonly we have two things, polyurethane foam and polyvinyl alcohol. Polyurethane foam have a 400 to 600 micron capacity. And this polyurethane foam is commonly what we use. It is sturdy, and whenever you want to have much of the granulation tissue is to be created, and it is better to use always a polyurethane foam. But however, in a small delicate structure, there is a lot of vasculature is there, vessels are opened, and then you can use the polyvinyl alcohol. And what is the parameters you are going to use. And normally when we are connecting with the negative pressure wound therapy machine, and the parameters, the pressure we need to maintain is minus 50 to minus 125 millimeter mercury. Commonly minus 120 we use. Even sometimes when there is a lot of pulses there, we can go up to minus 200 millimeter mercury. But ideally it is used for the minus 120 or minus 125. That is why sometimes even in the locally we can use with our existing the vacuum suctions, but maintaining an absolutely at the same level of the pressure is important. We can use either it's a continuously or intermittent, and many times when it is a very lot of pulse is there, debrided tissue is there, and when we are a large area, is a continuous is used. The two other technology is also there, and simultaneously allowing the intermittent, the installation of the water. You can use two pipes where you can use the negative pressure suction, and if there is a pulse generation is going to be high, and you can wash the wound by the installation. And most importantly, nowadays we also started using negative pressure suction and also oxygen therapy alternatively. You can give and the same wound, and you can use both that therapy. These are the different technology. And how long you are going to use and how much time you want to change. Normally we can use up to 3 days. If you are putting that one setting, the wound will be sufficient, you need not be able to change. Sometimes when there is more, you need to change for that. But you must be extremely careful, and when you are putting the foam or the interface on the surface where there is a delicate stretches are there, either you can use a sofa tool or something, can prevent the adhesions with that, and you can continuously. Remember, but this negative pressure is not an alternative therapy. It is a therapy in concomitant with other mode of therapy. You are trying to prepare the tissue for the granulation tissue you are going to create, and once you can get an optimal granulation tissue, you can definitely go for skin SSG or other methods of surgical treatment. But you must be, when you are saying the negative put therapy, the negative pressure therapy, you must be cautious. If there is not showing any improvement and it is continuously going for a difficulty, you must be able to switch over therapy also. This is a standard, the canister, the foam and use. But many times in our public health hospitals, we may not have, you can use an alternative methods also. What is the mechanism? This negative pressure wound therapy, how it is going to act. One of the most important principles is the mechanotransduction. That is, it causes both micro deformation and macro deformation. And micro deformation, because of the foam which you are using, which is going to shrink the structures, the wound size is going to reduce, and it is going to reduce the edema which is developing in the wound. It reduces the modulations of the inflammation, so thereby the inflammatory feature. It increases and augments the formation of the granulation tissue. It also plays a major role in the reduction of the bacterial burden of that, and most importantly, it helps in the angiogenesis and the neovascularization which is going to happen on that. So both the macro strain and the micro strain is helping on that. This macro strain, as I said earlier, the visible stretch that contracts the foam, draws the wound closes and edges together, and it provides the direct and complete contact with the foam and evenly distributing the negative pressure, and it also helps in the removing the exclude. Similarly, the micro strain is going to help on that. So this is a technique which we use sometimes when a patient is very poor, or in a public health hospital which we are not able to get the foam, or we are not having the full instrument, but still for our poor people coming to the hospital or even in a small clinic, when you are going to do whatever the material is available with us, and if it is a gauze piece and the Gamgee pad which we can put, and ordinary tubes which have one or two tubes which have the tube, we can place two tubes, and over this we need to put the Gamgee gauze piece or the Gamgee pad, which we normally all hospital will have that Gamgee pad which you can put on that. And only thing, we need to create a tight compartment in which there is some vacuum we need to create, and sometimes we may not even have a appropriate closure, and you can use an ordinary cello tap or ordinary tap which you have, and which can be used to appropriately close that wound. So once you put a complete coverage, these ordinary cello taps which we can use to make round, so that we are going to create a perfect vacuum area is connected with that. And once we can connect with some hospital, we have the vacuum section which we can connect. We have done quite a lot of, more than 120 cases we have in a series which we have done. And we could see, obviously, in most of the cases, and we could get a perfect granulation tissue where we can put the patient for so even if the wound like this, when it is very bad, and when we are able to put on a section, negative pressure section therapy, and we are getting good to get, and especially with wounds coming in the dorsal area, which are huge, and proper debridement, and appropriately putting onto that, we are able to get a good result in that. And this is a small set of instruments also we can use for that. Sometimes we can have the perfect closure also without going for a wound skin therapy. The wound, the size approximately very well it close. It takes a long time, probably, or 1 or 2 months, even sometimes we have to prepare. But once a good tissue we get, and it is a perfect area for us to complete. The second commonest way is it is a little sophisticated one. And you put the negative section. Also, you have an installation of the ozone. Ozone comes as in a liquid form. It is a N3, O3. It is a super oxygen therapy. So simultaneously, alternatively, you can use the negative pressure and oxygen. But we have not done much on that. But what this is another method which we always use is an alternatively putting a negative pressure suction and also simultaneously giving an oxygen therapy to that. And here we use a glove extra. In addition to that, we overtake the gloves and there will be two tubes will be there. What will be connected with the oxygen, which is commonly available in the oxygen tube which is coming there, be connected with that. One will be connected with a negative pressure suction. It is a group A. We did a study where we give the 5 minutes, 100% oxygen will be given. Then 30 minutes, this oxygen will be allowed to stay there. And then another 3 hours, we will be putting the patient on the negative pressure. So this goes on alternatively. And the group B, we have given only the negative pressure suction. We are not giving any oxygen. Patient will be given and continuously a negative pressure. In between the 30 minutes will be rest and patient will not have anything. So one group of people, we gave oxygen for that. And we could see the people who get an oxygen and the negative pressure, there is a faster wound healing. Infection rate was reduced much faster. The debridement, the area reduction was also high, area reduction. And there was no adverse event is noted for that. And we could do that before and after. And it produced an accelerated healing. It grows the tissue growth stimulation. It produces an infection control. It produces improved the blood flow. And finally, what was our dream and what was the effect was the limb preservation. And also, though we have, it is a good cost effectiveness is there because it is possible to do things with what is available with it. And if you have a facility, if you can go for the higher end and the good foam and good the parameters and vacuum, it is absolutely fine. And even if you cannot say that when it is not there, and we can always use local methods for that. This is a study which we have published in the PubMed on the comparison of the customized vacuum-assisted topical oxygen therapy and vacuum-assisted closure for the diabetic foot ulcer in a large volume of the numbers, 150 people we had a study. The study which we had done only on the vacuum-assisted therapy in the chronic non-healing wound ulcer. This again a study with combined with the oxygen therapy and the combination of these four. So just we are presenting this because our aim ultimately the preservation of the foot at whatever cost. And it is not a one treatment, is not an ideal, but you must be always trained and careful enough to choose an appropriate method and use it with preservation. Both the medical therapy and the surgical intervention therapy are important in preserving the limb so that we will be able to give a lot of service to the humanity in which we are living. So thank you very much for your hearing and looking forward for any of your questions to be asked. Okay. Thank you very much.
Check.
So in your clinical practice, this is one question which has come online, and they were asking about this therapy, what you are talking about, and how to go about in the hospitals, and is there, what is the cost of the therapy, the negative pressure? How much would the patient spend for the device and all?
See, now in Tamil Nadu, we have this system and they give the vacuum therapy and free of cost. And only when if you are getting the foam from them, that canister you are going to pay them. If you get a foam, which is a large area, it comes around 6,000 to 4,000. 4,000 to 5,000 is a roughly area, depending upon the average size of wound. That is enough. It is not that very expensive. And now we have a system in that Tamil Nadu especially, they come into your house and do that. The company, the doctor can prescribe. They need not even the transportation of the patient to the house is not necessary. In hospital is not necessary. Okay. People can come to your house. They do the this thing and connect it to the negative pressure suction therapy and do that. Otherwise, and if your doctor is a GP and he is doing that, he can do whatever the little he has, whether it's a glove or a gauze pad or whatever it is. He can create a vacuum there, and that will also helps in the maintaining of the ulcers.
Okay. So just to take it forward from here, what is the comparative improvement, how does it benefit in the time, the healing?
Yeah, that,
Like, is there, what is the, like, without a vacuum and with
the
vacuum?
three things what we personal is, and once you are putting, normally we say the diabetic wound, the dressing has to be changed alternate even morning and evening because the pus formation will be more. And here what we see, it is enough once in 3 days. You change that. That is itself is a big relief for the patient and that. Second, and on seeing the wound parameters which we have studied, which have been shown, so parameters we study, the reduction in the size of the wound is apparently very high because it helps both the macro stain technology and micro stain technology is helping. The wound, the edges of the wound is positively attracted towards each other. So there will be the reduction. So that is what we measure normally. So the reduction in the size of the surface area of the ulcer is very fast comparing with the routine ointment or the routine way of treatment which we are putting. This additionally helps in that reduction of the size. And also we'll very interestingly see the quickness with which the pathological studies are giving. The polymicrobial factors which we get in an antimicrobial study. And this itself, because the accumulation of pus is prevented and negative pressure is created, that itself results lethal to the bacteria. The sterility which is coming into the wound are much faster than the other methods which we are using as normal methods which we are using.
So, what I understand is that once the discharge reduces and there will be red granulation tissue all around the wound.
Yes.
And is there a possibility that we can go ahead with some collagen patches? Because there are also something which is coming and in a big way in the market, and at times should we wait or should we go ahead or should we do the conventional skin grafting? I just some questions.
Absolutely, that's what I said in the beginning. It is only an addition therapy. It is not a substitute therapy for anything else. And once you have created a good granulation tissue, there is fantastic collagen tissues are now coming in. The results are also good. And also in personal experience, what I see, even a normal patient have a good granulation tissue and diabetic patient have a granulation tissue. Good granulation tissue in a diabetic patient heals much faster than even in a normal person who has no diabetic food. But probably there's more angiogenesis is coming in, more amount of strain, they are putting a new tissue, they are putting that. So there is no absolute need, it must be only by the skin SSG. You can use by the collagen. Only thing the time gap, even if you are SSG, if you can appropriately put in, you can assure within another 10 days that won't heal. But collagen therapy definitely takes much more time. If the patient is good enough to wait for that, it is a good option for us.
Okay. Final question, that does silistazole help in wound healing? Because I read your one study which was published. So your views on that. Does silistazole therapy help in the wound healing?
No, that absolutely, because we did the study with a very controlled, one arm only on aspirin, one arm on the silistazole, and then we could apparently see 25 to 30% improvement in the fastness and the quality of the tissue, which we did study the granulation study, which was proved it is a faster, good, healthy granulation tissues developing with when you are adding silistazole. Because other things like it reduces the claudication pain, it helps the patient to walk faster. There is much studies are there, but there is only very few studies on ulcer per se or the effect of that. But our personal study, which has proved silistazole add on to the effect of making the wound heals much faster.
Right, sir. Thank you.
Thank you,
sir.
sir.
Thank you, sir. So there's one more.
Good evening, sir. Very well done personal series. I have two quick questions. Once we apply the VAC, do you have any strategies to assess? Especially sometimes we are equivocal about the foot vascularity status or debridement. Based on the outcome of the content, you decide that you don't want to go the typical 5 days or 6 days window, or second day patient is unwell, you need to re-inspect the wound. What are the parameters you in between break the planned NPWT?
Absolutely, sir. That's a very good question. Even the first, when you are shooting the debridement, and you need to be aggressive, but at the same time, hemostasis you have to secure. And if you are going a compromised vessel and putting on the negative head, you are going to be in a disastrous mode. So that is why I said, though normally we change once in 3 days, we will always check for the vascularity. If we are seeing what the pus we are getting is not a typical pus, and when there is the blood mixed things are coming, when there is a color of the blood changing, or even the vascularity compromise, absolutely we need to immediately terminate our then change to the normal way of that.
And you told about the improvisations done on resource constrained situation where we maintain based on the innate or indigenous methods. Like normally we are taught 70 to 80 millimeters wall pressure is okay for vacuum. Like does it mean if this vacuum goes little bit, many times these dials may not give the appropriate thing. So does it mean if you are going to put more vacuum, does it become harmful to the wound?
Definitely, sir. If it is, especially in the vascular tissue, in the second time when you are putting that,
Correct.
and we are going to make any pressure more than 120, that is going to be a little risky for that food. So
Okay.
better to keep on the pressure. I fully agree on you. When we are using the vacuum which in the hospital, you may not be able to have a sustained pressure.
Correct.
And there is also a paper which shows there is a continuous and intermittent suction therapy. So what we presume, though we say it is mandatory, we have a long time, 3 hours minimum. Even if there is a fluctuation, that is not going to matter much in altering the outcome of that. But if it goes high, it is dangerous. You must be very careful on that.
The other thing which we normally have seen is if the wound is off the vac, generally the slopy epithelialization happens well. If it is on the vac, good granulation is there, but that slopiness at the edge epithelialization doesn't seem to be that great when you are on NPWT. What is your observation, sir? Because if you are keeping the wound off the NPWT with conventional dressings, generally the epithelialization, slopiness and other things happen much faster. And especially when we are going for second vac, third vac on every inspection, assuming, then it treats a good granulation tissue. Somehow we find the edges are not that very great when they are not vac. Is that true, or do you have any special methods so that the packing is, the company fellow says, sir, you keep the pack, that part does not granulate. Granulate in the sense, does not epithelialize. So that part granulates, of course, but does it mean there is a delay we are creating?
And I have no personal experience. What we have seen, in the only trick is the approximate fixation of that, and approximately the size the foam is there. And obviously the foam itself is going to shrink, and that is going to pull the walls together to that. You may not have the typical the sloping edge, but when we seal vessels, we also put a Sofra tool in between.
Okay.
Because sometimes we are using gas.
But
So
the epithelialization, at least, but then it gives a very healthy granulation. But the gap, at times when you second vac, third vac, and fourth time you feel that remove the vac, it looks like the saucerization type of epithelialization is much rapid. I don't know, probably this
Maybe.
we put for very bad cases or so, maybe that is the case. Thank you, sir.
thank you.
One online viewer has a question. This is Dr. Usha Maheshwari from New Delhi. So for non-healing ulcers in diabetes, what should be the maximum dose of cilistazole, and for how long should we treat them?
Yeah, it's 100 milligram BD is the dose, sir. Normally what we are giving. But the effect starts not immediately. It takes minimum 1 month to 3 months for the effect to that. And cilistazole can be continued continuously. As we are going to put the aspirin, we are not going to say for only 1 case, because it also helps in the PAD in generally. So for the wound healing, we may go up to 3 months. And for continuation of that, there is one study which is exclusively on a cerebrovascular and cilistazole. So continuation of the cilistazole is not going to be a problem, and you can continue like you are going to continue like a Combus trial, clopidogrel and rivaroxaban together.
Right, sir. Thank you.
Thank you, sir.
Are there any questions? Can we invite? Thank you, sir. Thank you very much. A big round of applause for an excellent presentation. Thank you, sir. After 5 hours of drive,
And so we've been having a very enlightening session for the peripheral arterial disease process as well as the diabetic foot ulcer. Now, there is another extreme end of the diabetic foot ulcers and diabetic foot problems. It is the Charcot neuroarthropathic foot. And I'm going to deal on that particular topic because it is something not very common, but when occurs, it is a disaster. And it comes in a very subtle way. And that is why the topic, it's a great masquerade. So just before I go into the Charcot foot, I know there's a combination of orthopedic surgeons, general surgeons, vascular surgeons, physicians. How many of you have seen a Charcot and treated one? Can I have a raise of hands? Very well. So we have a very minority percentage who have seen and treated a Charcot foot. The majority seems to have not seen one, but this is how it presents many a times. And these are not Google pictures, these are all my own clinical pictures. And these are not diabetic foot ulcers, these are mechanical ulcers because of the disease called as Charcot foot. And what can we do about it? The whole idea, when I was a postgraduate student in an orthopedic, reasonably good orthopedic background of CMC, and I was told treatment is an amputation. Deformed diabetic foot ulcers and Charcot foot, why should we be talking about it? It is because, as the previous speakers have said, we in India are now dealing with the world's second largest population of diabetes. First being China, but the way we are going, we're going to defeat China in this very easily. And many of our the studies which are coming from India, I'm from Cochin, Kerala, and one of the studies done in Amrita had said 9% converts to Charcot. If you just imagine in 90 to 101 million population we have, if even 5% of conversion, then it is going to be very scary, and we should learn that amputation is not the answer. I'll come to that. And why is this problem? Because of the lack of awareness, because of the lack of understanding amongst all of us, and most importantly, it is lack of diagnostic tool and the concepts of multidisciplinary approach is not happening in India. And that is one of the major things which we are at loss. And many patients come with late presentations because they are not recognized early. And for example, this particular patient, this was an X-ray taken, I think, in 2017 or 18. That was when I was starting to focus on exclusively doing foot and ankle. I was a general orthopedic surgeon, and then I switched over to, in 2014, I switched over to foot and ankle and do exclusive foot and ankle practice today. And this was a patient who came to me with swelling, known diabetic, and I saw something there here in just, can I? But the pointer is not working. So if you look just above the navicular, that's a small spot there. And so if you look here, can you see a small speck? And I thought there was something there. I said, you might be having a Charcot. But then I was a foot and ankle surgeon, and in India, foot and ankle surgery was just evolving in 2015. The patient obviously went for a second opinion, and the senior surgeon, whoever saw it, said, no problem, you don't have a problem, this is cellulitis. The same patient comes back to me after about 2.5, 3 years with this Now the whole foot is completely changed. What was a normal arch foot is now become a rocker bottom foot because the whole midfoot has collapsed and the shape of the foot has become like a boat shape, or what we call as a rocker bottom. So what was like this, which could have been simply treated with a plaster, no medications required, now requires a surgery because of the non-healing ulcer here, and no amount of your medications or WAC would treat that because this is a mechanical problem. You need to treat the mechanics. There's no point of treating this with anything, including footwear. This was again a patient who came to me, and this was the history. 15 to 16 years of diabetes, had redness, gross swelling, diagnosed as varicose veins and then cellulitis. Surgery was done for the varicose veins, but the swelling persisted. And then suddenly he said, I just couldn't walk because the limb gave away. And this was the X-ray. So you can see the whole ankle was destroyed. That was the reason of the swelling. A simple X-ray would have helped. But the problem was the swelling was not diagnosed as a Charcot foot at the initial stage. And that is the problem. The swelling around the foot and ankle, if it is persistent, please, if one point, if you want to take it from my presentation today, just go back and take an X-ray. That is a life-changing, a game changer for a Charcot foot. So next time you see a swelling in a diabetic patient with no pain, the counts are normal, think it is the Charcot. Because in cellulitis, the infection would be there, the counts would go up. Here, it is aseptic. So what are we talking about of Charcot? What is Charcot arthropathy? It is a relatively painless. The patient does not have pain. They'll be walking. Even with all the deformity, they will be walking. It's a non-infectious. Patient will have a lot of swelling and warmth also, but it is non-infectious. It is degenerative. The body is eating up your own bones in a single or a multiple joints with a neurological deficit. And this neurological deficit is the problem. Patient does not have pain. There is something causes known as the LOPS, that is loss of protective sensation. And that is the problem. The protection is not there, so the patient would walk. A small trigger of trauma, small twisting injury, small hit in the side of a chair can start this triggering factor, and that leads to TNF-alpha cells, Rankel cells activated, and that is leading to the osteoclastic activity. And that is why the Charcot activity starts. So in acute Charcot foot, it's basically the swelling, erythema, there is warmth, but there is most of the time no vascular compromise. Now I am saying most of the time means it's about 80 to 87% as per the documentation. There is no vascular compromise. There is a 10 to 12% vascular compromise, and those are the very dangerous guys, because if they don't recognize, they go for an amputation very commonly. Charcot differentials, as we have said, cellulitis, osteomyelitis, deep abscess, stress fractures, these are all differential diagnoses. You need to know. Why? Because you just cannot treat these two tummies together in a similar way. They are completely of different origin. You need to understand what is the treatment. So how do we treat the Charcot neuroarthropathy? Is amputation the answer? The simple thing is take a history, cardinal features of diabetic foot ulcers versus Charcot is very helpful when you examine the patients, and then many a times a diabetic foot ulcer would have a very feeble pulse or no pulse, while a Charcot will have a bounding pulse. Doppler you take, it might be showing monophasic, but it is a high velocity monophasic. So that's the difference. Even if you have a monophasic, it's a high velocity monophasic. X-rays are very, very important here. Early stages, of course, you might have to have a high degree of suspicion, but over a period of time, X-rays shows how the bones fragment, it completely destroys. So high degree of suspicion is important. Ultrasound is not very helpful. MRI is sensitive but not specific. Your radiologist needs to be, needs to know what is Charcot. So radiologist also has to be taught about this problem. Scans, only iridium scan, which is not available in India. So that's bone scan is also useless to compare between the Charcot and the infections. How do we, once you recognize, how do you classify? The Eichenholz classification still holds good. It's an X-ray classification from normal looking to completely fragmentation, coalescence, and reconstruction. So this is an X-ray clinical classification. These are the time you should recognize in stage 0 and 1 because the treatment is simple. When it goes to stage 2 to 3, in deformity leads to treatment from major surgeries to an amputation. So these are another classification, Brodsky's classification, depending upon the area of involvement. The goal of the treatment is to reach a stage of consolidation in a stable, non-deformed condition, and patients should be made ambulatory as much as possible. So stable, plantigrade, walkable, ulcer-free foot is what we need to have at the end of the treatment. And the treatment here, what I was talking, plaster, is something called as total contact cast. Now, many orthopedic surgeons, friends and all, they call me and said, how many days? These are not for days, these are for months. You need to keep on changing the plaster. You need to keep on non-weight bearing for a pretty long time. And then once the stage of fragmentation goes on to stage of consolidation, that is the time you start weight bearing with the plaster initially and then to something called as crow boot. The original TCC is like fully covered. The problem with fully covered in India, especially in South India, where we all practice, is the humidity cause. And that leads to a lot of problems. So we actually modified these way and we started keeping it open. We published this recently and that has helped us to reduce the humidity factor causing problems. Then it leads to what we call as the crow boot. That is what is the patient what walks. Now I'll show you a few examples rather than going on with the theory. This is a patient who came again with a swelling. This was coming to us. The patient did come to us, came with a swelling and a small abscess. We removed the abscess, but the swelling persisted. And if you look at the X-ray, there's no pain. And the problem was there's no pain, but there was this persistent swelling. So we did the abscess management, and then when the patient came back in 1 month's time, I saw there was some problem changes. And if you look at that area, you can see if the orthopedic surgeons are very easily, you can see there is destruction at the TMT joints. The second and third TMT is slowly starting to disintegrate. These are the time when you should pick up, because the treatment here is just the plaster, nothing else. No other medications required. Of course, the sugar has to be controlled, but if you manage at this plaster level, total contact cast given, it just heals on completely, and the patient gets the foot normal back and see the stage of consolidation, no deformity, nothing has happened. And so a high level of suspicion is what is a treatment. People have started to give the calcitonin sprays, bisphosphonates, nothing works. We have enough and more literature, nothing works. Recently, denosumab has been said to decrease the rankle cells. We are also doing a study between the 1 dose versus 2 dose. It just decreases the fragmentation stage. It doesn't do more than that. So denosumab just reduces the amount of fragmentation, but it is early studies. We still have to wait for a few more years to get the effect of denosumab. But otherwise, other than denosumab, nothing works. What is the problem if you do not treat? Because then the deformity becomes big, the ulcer becomes big, and the foot is unstable. The indication for surgery here is deformity correction, ulcers at prominence. You cannot wear a shoe or a brace or an orthosis, and of course, there is an infection which is spreading across the body. So, if you look at the Charcot leading to an amputation, you can see the Charcot with an infection leads to almost 1100% of problems. So 12, factor of 12 is a huge amount of problem leading to when it becomes a Charcot becomes infected. So a few cases again, this you saw the picture, the patient came back to me after 2 to 3 years, and 3 years with a whole lot of problem. The ulcer was not healing. So the ulcer was not healing is because of this problem. The cuboid has gone down, and that is the reason ulcer is not healing. There's no point of just stressing that time. You need to remove those cuboid. You need to bring the foot back into normal, and that is what we did. It might look very plenty of implants inside, but see the foot after the surgery. What was there, and now with the implants, the foot looked much more smaller. So that is the thing which we have to do once you have a non-healing ulcer with the problem of deformity. And this is how the patient, this was way before Corona, and this is how he used to send me pictures during the COVID times. So the case number 2, much more bad ulcer, very much patient was absolutely bedridden. We did 2-stage because it was gross infection. We did an exhaustectomy. We removed all the infected bones. And again, the emphasis of multidisciplinary approach is very important. You need to have all your teammates, your endocrinologist, your infectious disease, you at times nephrologist, cardiologist, everybody needs to be there in this particular picture. Again, the ulcer was because of the cuboid going down. We removed that and put some antibiotic beans. Once the wound got healed, we reconstructed it. We got the whole thing back. We used something called as a beam screw, and you can see the difference from what there to here. So the mechanical problem has to be treated here in this particular case. This was a case where both hind foot and the midfoot, both were involved. And see the patient, how she comes. In spite of so much of damage, she is walking pain-free with so much of deformity, but still walking pain-free. The problem is she just couldn't go out for her social activities, and that is why she came. She said, I can't go for my marriages, and that's the problem. I don't have pain. So you have to understand that Charcot disease does not create a pain because of the extreme neuropathy. And so here we did, you can see the whole metal around hind foot, midfoot, completely metalled. It looks outrageous, but you look at the change which creates to the patient. This is now almost 2.5, 3 years follow-up. She still comes back. I say, you have to visit me like a Tirth Yatra every 6 months, because I don't know how long it's going to last. Believe me, I do not know how long it's going to last. We've got 5 years follow-ups now with a lot of problems. We have started publishing a lot of patients, a lot of things, but it is a problematic. But we are saving the patient's life, we have patient's limb from amputation. This was another case who came, forget about this theory, this is how a patient came. Completely dislocated at the subtalar joint. The patient was actually walking on the talus. What you see, that wound, is actually the exposed talus, and you can see the X-ray and you can understand how the patient was walking and still walking. This patient came to me walking, and this is a photo actually walking. So this is something you have to understand, such a bad wound. He has been on treatment with all the therapies, negative therapy, everything, but the wound is not healing. The problem was he was actually walking on a dislocated subtalar joint and the wound would not heal. But surprisingly, in spite of all this, the neurovascular bundle, the vascular bundle was intact. And that was what I was actually, while I was operating, I was like, oh my God, we did a vascular angio, everything we did, somehow managed to get the thing. By the time patient came, he was also infectious. So we did we have a multidisciplinary approach team. We got everybody involved. We do not do everything. So once everybody got the clearance, the sugars were reasonably managed, we do this something called as the antibiotic coated tense nail. We have actually done this on a whole lot of patients now, and we bring the debride, put the talus back, whatever the talus is remaining, and then we got the wound healing in about 4 weeks' time. And then in 6 weeks, once the wound was completely healed, we went back, removed the nail, and did a final reconstruction. So you can see 1 year follow-up, the wounds have completely healed, the foot is normal, the patient is walking with his own feet. And this particular the technique which we have kind of published lately. So is the surgery approach safe? Yes, it is safe, but it has got a lot of problems. If you do not have multidisciplinary team approach, you are going to be in soup. Because after doing, we've probably one of the India's largest series of Charcot foot. I get patients from across India. We've reached now more than 200 of major reconstructions. And believe me, it's not easy. After surgery, the patients, if they have a peripheral vascular disease, they also have a cardiac disease. So they will have a whole lot of problems, nephro problems, everything. So you need to have a team approach. You cannot do it in isolation. And why you should do this in spite of all this complication is because, as Sir was saying, amputation is not the answer, because if you amputate, most of the patients will have a mortality, and this is second to lung cancer. So we all talk about cancer, cancer, cancer. We do not talk about amputation in diabetic, especially diabetic and Charcot foot, because that is the second cause of the major mortality rate in 5 years. We all should know that, and we all should be working hard to prevent the amputation, to diagnose this early, and to take the patients without mortality. These are the few our own publications in different journals, and we're trying to learn and teach world over with our series. I was asked to say something about the hot feet. This is one patient who came actually he's a big-time lawyer in Kolkata, and he had this 5 different ulcers. He came to CMC Velo, and they said amputation. You see this X-ray, and as an orthopedic surgeon, Dr. Shobit, you can say how many bones are there. It's almost half of the calcaneum is eaten up, and this is the ulcer. His renal parameters was 1.9 creat, 12.5 was the HbA1c. the Doppler study was monophasic, and he was in sepsis. I think the count was 27,000. So, of course, the life saving is amputation. But he came, he said, I'm ready to die, but I'm not ready to amputate. So the CMC, I've been a part of CMC Velos, so they said one guy is crazy there in Cochin, you can go to there. So he came to us, so we debrided, we did this SWAC, we did everything for him, got the treatment in multidisciplinary team approach again, and slowly, again we did the same thing, we stabilized with an antibiotic rod, and then you can see one after another the wounds started healing, and the foot started to grow back to normal, somewhat normal, I won't say normal, and with whatever bones I had, I fixed it, just to give a stable, this thing. The last year I went to Kolkata, and he came to meet me, and this was his foot. And this is how, what he was, and this is now, you can see how the nature provided back the calcaneum, what he had completely lost. This is not my doing, this is how the body reforms. And look at that beautiful contoured foot, and see how he walks. He came from the court directly, so you can see how he walks with such a bad ulcer which he had. So friends, as I conclude, we should understand Charcot foot arthropathy needs a better attention. Prevention is definitely very important. Take an X-ray next time when you see a swelling in the foot. It is not cellulitis, it may not be varicose veins, it could be a Charcot neuroarthropathy. And when you're treating it, remember, multidisciplinary approach is very important, and amputation is not an answer. Thank you very much for your patience. Any questions?
And most of your case series had some amount of open wound, either in the form of trophic or some form of granulation stuff, which is open, right? I could see you do in a stage manner where you do a temporary implant, probably it controls the sepsis to an extent, but still I could see some wounds are yet to close, and then you end up having your second complex reconstructions, or at least to stabilize, to give a stable foot.
Yeah.
How many of your series patients require metal exit at some point of time?
40%.
40%.
So metal breakage is there. Most of our metal breakage happens at 36 months.
Okay.
It doesn't happen in 1 year. It doesn't happen 2 years.
I know.
So when you say I have done an excellent job and my 1 year result is excellent, I always tell up in the crowd, see, just sit and watch. My problem started happening at 2.5 years. And but good thing is I have only removed, I think, less than about 7% of implants because of his breakage. Because by the time the patients have got bony as well as a fibrous consolidation. So fibrous union is also very important. It is kind of accepted union world over. You do not get bony union all the time in spite of meticulously preparing all the joints, but 40% of the union happens only fibrous, 60% happens bony. When you're doing hind foot, you have to be very careful that your ankle and your subtalar joint needs to be united, but when you're doing mid foot, because there are so many joints, that's okay. Chalta hai, it's like we can manage it. But then implant does break, and you just cannot use the foot implants which are 2.7 mm. It has to be as thick. So the beam screw are 7.3 mm, which was, as an orthopedic surgeon, I just cannot think I can use this
Could
amount
see
of
the PFN
implant.
level screws across the bones. The other thing is, like these patients, when you say category grade 1 and grade 2s, early intervention gets in. What type of early, because in your series, most of the cases were fairly advanced, grade 3 plus.
Yeah.
So 1 and 2, what type of intervention is the current recommendation?
So even if the patient comes in 3 and 4, my first and foremost treatment is total contact cast.
All right.
So I do not operate on patients who have got fragmentation and they are reasonably in position foot. I feel they do get better with normal way of healing. So total contact cast is a very important treatment for me. For me, a surgery is very specific. I mean, since I get a referral from all across, that's why the numbers. But it is not because I operate on all the foot. My series is only about 38% of surgery. The rest
lot
is
of them
all
go
conservative management. And if I take the whole series, has gone to more than 500 cases, but then is that the surgery is 200 is because I am very specific of not operating on a stable, non-deformed Charcot foot.
One last question. Can the first stage be Elizarov and then go for a
Sir,
definitive
I mean, I do not know how to do Elizarov.
All right.
So I do not. I
You're
am
too honest. Thank
yeah.
you very much. Because Elizarov seems to be more of a minimally
Yes.
invasive
So
stuff.
so
You don't put anything inside.
Elizarov is one of the accepted treatment.
Yep.
But the problem with the Charcot foot is what I feel against Elizarov is if I operate on Charcot foot, my minimum time of bony union is around 4 to 5 months.
All right.
How many patients will tolerate that 4 to 5 months of big Elizarov construct is the problem. And what I have started, I mean, what I get to patients coming from after being dying Elizarov is a fibrous union rate is much more higher in Elizarov than in this. Because for me, if I operate, the protection goes on to 8 to 9 months. 3 months of total contact cast after surgery and 5 months of crow boot after that. Only after that they come to the customized footwear. So I'm very meticulous. I tell them before I operate, you have to be patient. I'm going to be patient anyway. But if you cannot be patient and if you want to run around, please don't come to me. Go away right away.
Much appreciated, sir. Thank you.
You said about that cast therapy, no? What is the incidence of DVT in those cases?
Surprisingly, very, very, very less. Very less. In fact, I probably haven't seen one. Though, yes, I do Doppler in almost all the times. I do the day 1 Doppler. I do a day 3 months Doppler to see, because initially I was very, because you keep on changing the plaster and you, maybe it's monophasic. That is why it doesn't have this thing, but very less.
Would you advocate any prophylactic heparin therapy for those patients?
No, all these patients are on Celestosol as well as aspirin. So possibly that is also helping us out in not having DVT.
So I think it was an excellent talk. One question from an orthopedic surgeon from Gorakhpur. And his question is, am I medico-legally safe if I put a TCC in this part of the country? For this cases, probably there are doctors who believe that it will lead to infection. So, is it safe from a medico-legal point of view, he is asking.
I would probably put it in another way. If you do not put a total contact cast,
then you will have at least someone can challenge.
Send him to Kochi, we will take care. Right. So that is the answer, guys. Thank you very much. And excellent talk once again. A lot of things to learn and, of course, not to do. That was more importantly. Thank you very much. Thank you, Dr. Jailal, sir. I will request all the audience, all the delegates who are there, please join for dinner. And thank you very much for making this event a successful, a valuable for us. There are a lot of learnings for us. And I believe that once you go back, we will also think, and you also think of the precautions and the cautions what we have to do in our surgical practices, and of course in the medical management. So thank you very much. I wish you all the best, and please enjoy the dinner. Thank you.